And now it's my honor to introduce one of our hosts today, Dr. Mollie Carruthers, a Canadian leader and global expert in IgG4-related disease. Dr. Carruthers has been instrumental in advancing research and patient care and in strengthening connections that bring our community together around the world. She was also a guest speaker at our first Jamboree, the JAM, and it was such an honor to have her in the Canadian voice come to Washington, D.C. So thank you again for that, Dr. Carruthers, and thank you so much for being our host today. Welcome.
Thank you, Catherine. Yeah, I'm signing in from Vancouver, Canada, so it's morning for us. So good morning, everybody. Welcome to the first patient advocacy meeting, first Jamboree that's held in Canada. Thank you so much for IgG Forward and to my mentors, Dr. John Stone and Dr. Luke Chen, and Catherine Provencher for putting this all together. It is not easy. And I'd also like to say that for my session, my lovely patient, Danny Luo, she translated this entire talk into Chinese. And so that will be provided in the chat. So please look for the chat in classical Chinese, traditional Chinese. Thank you so much, not the simplified version. And without further ado, I will start my talk, which is entitled, Why Does Getting the Right Diagnosis Sometimes Take So Long? Here are my objectives. I'm going to explore the typical IgG4-related disease patient journey. I'm going to talk about common pitfalls in the diagnosis and maybe why they happen, kind of examine that with a lot of granularity. And as I go, I'm going to talk about not only patients' role in their care, but potentially patients' role in raising awareness in this rare disease. So take a moment here and think about an analogy. Okay, I'm going to make an analogy here. This is a picture of the river map of the Lower Fraser River in southern British Columbia. And you can see the patient in the middle there. And I'm going to make an analogy that a patient getting from this point in the river system all the way down to the ocean, which is the diagnosis, it has a lot of twists and turns. So you can imagine a patient is like a small creek tributary, just this little bit of water, right? And the patient has to make it from that little bit to a wider creek, to a small river, to the bigger Fraser River, and finally out to sea where they get to their final destination, a diagnosis. This is Rainbow Falls in Whistler, Canada. And this tributary isn't stopping, right? It's going straight out to sea, nothing stopping it. And maybe this is akin to a more common disease, less twists and turns, less obstructions. So why doesn't the average IgG4 patient act like a roaring rapid of falls straight to the diagnosis? I'm going to touch briefly on the complexity of IgG4. This is not a physician audience, so all of us don't need to know how to diagnose the disease, but I'd like maybe you can see yourself or a caregiver in one of these four patterns. It's an oversimplification of a complex disease. So there's pancreatobiliary on the left in blue. This is if IgG4 grows in your pancreas or your liver. In purple, retroperitoneal fibrosis or aortitis. Then in blue, head and neck limited, that's if it's in your eye or your salivary gland or your loved one. And then Micklitz or systemic, that's when it's all over your body. And each one of these colors actually represents 25% of how patients present. So that may speak to you, it may not. Or maybe I'm just showing this to show you how complex this disease is and why it can take us so long, because one disease can present in all of these different organs. This is a complicated slide, so bear with me. I did use some color coding here to help us. So in the top left in gray, the family physician. That is the first person that you go to, first doctor when you have IgG4, right? And you have a symptom like you have eye swelling or maybe a gland, or maybe it's just you don't feel well and you don't know why, or you have some abdominal pain, right? So you get some labs done and it shows an issue. Maybe it's in the liver and kidneys, maybe it's in your eye. So the family physician sends you to the first specialist, which I've denoted in brown. And for example, one of my patients had eye swelling, and the first specialist, highlighted here in brown, was an allergist because from his symptoms, it was thought to be an allergic reaction. But unfortunately, this first specialist only sees common diseases and has never even heard of IgG4. So you just go back to your family doctor. Then in burgundy, you go to the second specialist, and they know this is complex, and they may be thinking about IgG4-related disease in their differential, but they don't really know much about that, and they don't know how to diagnose it. So then in the bottom left, also in gray, you go to the third specialist, and they say, aha, I know about IgG4. This is what it is. And the patient thinks, okay, I've arrived, it's done, I'm at my fourth doctor. But unfortunately, that specialist doesn't actually know how to manage or treat the disease or what it looks like moving forward, but they can make the diagnosis. So bottom right in orange, definitive specialist. That's the person you go to that manages your disease going forward in time. So I'm going to break this down a little further. I have this schematic here. It is loosely based on a single patient, but I think it can be representative for how a lot of patients present. So I'm going to go through each of these streamlined steps and look at the pitfalls, okay? So let's look at where we could enter. It's a pitfall, but it's also a potential, an opportunity in the positive to get at this disease a bit earlier. So let's focus on your GP, okay? So why doesn't your family doctor recognize this disease? They could avoid all of the middle portions and be like that waterfall straight to the ocean, right? Bypass all the flow. Well, family doctors don't have it in their textbooks, and maybe they would make an argument they don't need it because it's rare. They have many specialties to cover: surgery, obstetrics, pediatrics. This is one disease of internal medicine, of rheumatology and hematology. So because it's an uncommon disease and it's not in their books, and maybe it doesn't need to be, but they've also just never seen it before. So that can be really tough. But the patients themselves, in terms of patient awareness at this step, I think it might be difficult just with an initial symptom to diagnose yourself, because at this point, I'd like to say that the possibilities are actually endless. So why doesn't the next specialist, right? The first specialist that you see, they're often an internist. Why doesn't your internist know about IgG4? So internal medicine doctors don't have the IgG4-related disease in their subspecialty boards. Now, under John Stone, that may have changed. I took mine, 11 years ago in Canada and the US, and it was on neither of those. And so if you think about it, I'm a relatively young doctor, right? So somebody who took their boards 30 years ago, even if it starts now educating the doctors, there's still all that time before where it wasn't on your boards and it wasn't in your textbooks. Then I'd like to talk about rounds for just a minute here, internal medicine rounds. They could discuss IgG4-related disease. This is a place where a lot of doctors learn in internal medicine, is actually in the hospital, and they go there for 2 to 3 years, and with subspecialty up to 6 years. So on rounds at the hospital, they may not have this ever come up, again, because of that rarity. And if it does, that is a good education point. So what about patients? How could patients intervene at this first specialist? Now they have maybe a little more granularity about their symptoms and labs. So I do recommend Dr. Google. I mean, we all do it. And then with the advent of artificial intelligence, sometimes that's built in right into your Google search. And then ChatGPT. Now, I've been on call recently and I put a rash into ChatGPT. And I'm not a dermatologist, but I didn't think it did a great job. But I have noticed when I use Dr. Google for my disease exploration that AI is actually quite good if you put the symptoms in. So I think there's no harm in that. And any doctor who's afraid of Dr. Google, is a bit insecure because we all need to help each other to get the diagnosis. So asking for IgG4 subclasses, I'd just like to put a plug in there that I think that actually patients could ask for their IgG subclasses because this is a new lab test and it's for a new disease. And maybe that could fit. Maybe we could raise awareness that way by sending a few more IgG4 tests. So other thoughts, this is my busiest slide, so please bear with me, and then we'll get back to a beautiful picture of beautiful British Columbia. So let's say you go to your second specialist and they have heard of IgG4-related disease. It's not only on their differential, but they think of it. But they're a bit unclear how to work it up. And so they're also unclear on how to treat it. And so again, where's the patient voice in here? You could ask the doctor if they've seen a case. I don't want to, plant in too many seeds here, but in a very non-judgmental, nice way, just like, oh, have you seen this disease before? I don't think that that's bad. And also word of mouth, if you know somebody in a rare disease community personally, you could ask them. And actually one of our patient panelists is going to talk about how having one rare disease can actually, in a caregiver, can lead to diagnosing another rare disease. And then in the middle panel, when you see the third specialist, they make the diagnosis. They've seen IgG4-related disease before, but they don't know how to treat the disease. So you're really almost there. I don't have any particular suggestions there, but to get from the third specialist, the definitive specialist, that would be a hematologist or rheumatologist or an internist. They have comfort with complex disease management, and they may or may not be a local expert. I will take questions at the end. Thank you very much. Yes. So they may or may not be a local expert, but where do the patients fit in here? I wanted to put a plug into IgG Forward, okay? So IgG Forward has a list on their website of all of the experts in cities across the world, and I would like to put a plug in to grow that Canadian list, especially after today when we have all these fantastic Canadian speakers coming. So another little brain break here. This is Brandywine Falls near Whistler, Canada. And you can see that there are two rocks that are narrowing this glacial melt. So we've already discussed pitfalls and obstructions to getting a diagnosis. What other obstructions can we think about in getting a diagnosis of this rare disease? So tissue is the issue. Many of you will have presented with a mass initially, whether in your pancreas, in your lung, anywhere in the body. IgG4 causes mass lesions. So cancer is often the first thing that you and your family doctor are worried about. And then when you go to the surgeon, the reluctant surgeon in brown there, they say, no, you don't have cancer. Cancer is only one gland, or cancer would grow more quickly than this. This is inflammatory. So then you go to your specialist, the specialist asks the definitive specialist, and they say, well, I'm sorry, I can't make a diagnosis without tissue. This could still be cancer, or it's an inflammatory disease, but there's lots of mimickers for IgG4. So then the patient goes back to the surgeon discusses the risks, and that's at the bottom, the reluctant patient. Now, this is completely understandable. Biopsies are invasive. They can be painful, but I'd like to put a plug here in this talk that if we could have more patient awareness, how important a tissue biopsy is in IgG4-related disease and all of its mimickers, I think we could all work together to decrease that timeline of patients getting a diagnosis. Rural versus urban. So this is something that a lot of us don't always think about, how living outside a city in a rural area may affect our care. So you might have no specialists in your area. You might have to travel extensively, 6 to 8 hours, 10 hours, take flights to get to a specialist in this rare disease. So you might be in a city without an IgG4-related disease specialist, which we just discussed, and I'd put another plug in here to check that IgG Forward website. Okay, so this is a chart So this is an estimation of how many of you in my practice have seen these types of specialists. So essentially leading up to the diagnosis, like 10% of you saw an ophthalmologist first and they sent you to me, or a quarter of you have seen a gastroenterologist first and then sent to me. So you can just get this breadth here. How many specialists are involved in your care? How complex this disease can be. So rheumatology, sometimes you come straight to us, but quite rarely you can see you go to a urologist first or a nephrologist or a respirologist in ear, nose, and throat. So actually behind the scenes, all of us specialists are actually working together to get your IgG4 diagnosed and managed. And a global perspective. So just want to take a minute to say that we're very fortunate in Canada. I'm just going to go through a couple interventions that are available, such as IgG subclasses. So this is a specialized test and not available everywhere. Or imaging like a CT or an MRI. And maybe most importantly, specialized procedures like endoscopy or urology are not always available. And then on treatment, many countries only have access to prednisone, and some may have access to pills like azathioprine or mycophenolate. These are in a class called DMARDs. And very few have access to innovator biological agents. So we're very lucky. But also we have to consider how this factors in for our global perspective. I'd like to talk briefly about ethnicity. So pictured here on the bottom left is a map of Germany, and in the top middle is Japan, and on the bottom right is China. So I wanted to make a special note that on the bottom left, Germany, that is where IgG4-related disease was discovered. So doctors Kuttner and Miklitz first recognized IgG4 under a different name in the late 19th century, and that in this regard, Europeans do get this disease. And then in the middle is Japan, and IgG4, the biomarker, was actually discovered in Japan in 2001 by Dr. Hamano. And then bottom right is China. It may be, although the populations are also bigger, but it may be that IgG4-related disease is more common in Asia. And the Chinese now have the largest patient cohort in the world under Wang Zhang at 1,500 patients and counting. And she's actively involved in research with myself and the rest of the researchers on the call. This is a picture of Inuksuks at the Gibson Shore. So we went over a lot of management, diagnoses, pathways for diagnosis in IgG4, and maybe how we could come up with some solutions together. And now we've arrived. We're at the shore. We're looking at our Inuksuks, a very peaceful place. We think about the long path that it took to get to this seashore and get our diagnosis. And now that we're there, how do we get more people to join us? How do patients help with raising awareness and diagnosis of this disease? So a couple thoughts I had, and I'd welcome that in our question and answer session very soon. I propose an unfunded mentorship program between patients. Just a conversation by phone or email or in person if you're comfortable. If you're a patient or a caregiver living with IgG4-related disease, be willing to talk to one other patient with the disease. Ask their doctors if they know a patient like themselves. Go on social media, join IgG Forward, support IgG Forward. And being willing to help just one other person, you don't know that this will help everyone with this disease. And here's my line of intimidating doctors. Yes, it's true. We like to be in the know and the patient not, but we learn too. So talk to your doctors about IgG4-related disease. Have they heard of it? Even if you already have the diagnosis or not, would they be willing to listen to your one-sentence story? And blame IgG Forward. I'm part of a group that's trying to raise awareness of this rare disease. And whether the doc has heard of IgG4 or not, they'll learn from listening to you. This is my final slides. More thoughts on possible role of patients. How do we raise awareness, join and start patient advocacy groups here in Canada, communicate better with our doctors, advocate on social media, do education and networking, and how do we reach out to the larger rare disease community, such as celebrities living with the disease? Thank you. I'm ready for questions. How am I doing for time?
You're just fine, Molly. We have time for a couple of minutes of questions, and we have some questions in the Q&A, which I will summarize for you because you can't see. The first one is actually about CT scanning and asks whether CT scanning or CT scan with contrast is the best approach for detecting inflammation or fibrosis in IgG4-related disease. What are your thoughts about that?
Yes, thank you. Thank you, John. Actually, John led a study when I was still in Boston on using PET scan in addition to or instead of or in comparison to CT scan. And we found that actually CT scan was pretty equivalent, that PET scan does help us in terms of seeing disease activity, but the soft tissue infiltration that we see with IgG4-related disease can be seen on plain CT, and you need contrast if there's something like aortitis. So there's specific cases where contrast is needed, and our radiology colleagues often help us with that. And then there's certain areas where we might need an MRI, especially in the eye. We like to look at how close the soft tissue infiltration is to the optic nerve, but even there, it's not always needed. But it is a very important diagnostic and monitoring tool, CT scan. So we do often repeat for monitoring every year for a couple years. And I do worry about doing too many of those in terms of total radiation exposure for my patients. So that's a conversation I have with them.
Great. So we have about 3 or 4 minutes, probably more, for questions. We have several questions. We may not be able to get to all of them here, but we'll do our best. And we'll move on to the next presentation at 12:45, which is the patient panel. So the next question is, do you see elevated levels of platelets often in IgG4-related disease?
Well, platelets can be increased if you have a lot of generalized inflammation in your body, also associated with C-reactive protein and some other things in the blood. So I would say it doesn't help me with a diagnosis of IgG4-related disease, no, but I do observe that, yes. Especially.
Can I make a comment, Molly?
Yeah, please do.
Yeah,
Platelets
right.
is your thing. Yeah, please.
Hi. Yeah, so it's Luke Chen here from hematology. I think there are two things to think about. If the platelet count is very minimally elevated, like 400, 450, very hard to know what that means, if anything. I will say that there is an important mimicker of IgG4-related disease called the idiopathic plasmacytic lymphadenopathy variant of Castleman disease. So some people, if they have a very high C-reactive protein and chronically elevated platelets, they get mistaken for IgG4-related disease because they have elevated IgG4 levels, but they actually have a form of Castleman's, and the treatment is somewhat different. And then anecdotally, I do think there's a little bit of an overlap with a myeloproliferative neoplasm called essential thrombocytosis and IgG4-related disease. I have at least 4 or 5 patients in my practice who somehow have both because you're allowed to have 2 things at once. So I think those are some things to think about and ask your doctor about. But again, it depends on how high the platelets are. If they're persistently more than 500, that probably does require some further investigation. If it's like 400, 450, that's very non-specific.
Luke, what about cold agglutinin disease? Have you seen that with IgG4? I have 2 cases of that.
Oh, that's interesting. It's not personally something that's
Yeah, it's not on the radar. It's on the
yeah.
literature. Anyway, more to come on that.
Yeah. But the good news is they often respond to rituximab. So
yeah, that's true. That's true.
2 birds with 1 stone.
So Luke, your interjection anticipates perfectly the next question. The question is, isn't a big problem the lack of coordinated care where multiple specialists are provided symptoms. And here we have on this Zoom call the ability to pull in an expert hematologist immediately on a question related to platelets. It's not so easy in the real world. What do you think about that, Mollie and Luke, while you're on the importance of coordinating care?
Well, that's why I put that chart up, just kind of to represent all the different specialists. And I think that's an area of growth for us of how to work together better. And it's also just a feature of the healthcare system. You know, if you go do, somebody in the patient panel is going to talk about their sojourn to the Mayo Clinic. At the Mayo Clinic, you can see every specialist on the same day, and then they have a conference about you. So unfortunately, in the real world, that's not how it works. But we're already bringing interdisciplinary conversations and awareness by having talks today from gastroenterologists, hematologists, and nephrologists, and so on. So being part of IgG Forward actually helps your care as well, bringing us all together.